My passion with congenital short femur started in 1993. This paper, I was a co-author with Franz Grill, Pavel Dongel from Czechia, Steinwender. Steinwender is a professor of pediatric orthopedics in Graz University. And we showed the experience with 51 cases. And after all these years, after 27 years, I found out that I've been dealing with most of the cases the same way in this paper. I'm going, I've been through all the classifications, and I think none of them is really valid for congenital short femur. So I developed this classification. 4 types for congenital short femur or proximal femoral deficiency. Type 1, morphological abnormalities of the whole femur. Type 2, congenital abscess. A, total abscess. B, partial abscess of the proximal femur. Type 3, abnormal proximal femur. A, apparent neck pseudoarthrosis. It's not pseudoarthrosis, it's apparent pseudoarthrosis. Type B, coxavar. 4, short femur. It's almost normal femur, but short. And I will show you the classification. Regarding hip dysplasia and the instability, it's not related to the severity of the problem or something. So you can have a case with whatever it is, coxavara and mild knee and severe knee instability. So you have to test each patient for hip dysplasia and knee instability. Hip dysplasia is not the acetabular index or the central edge angle or something like this. In most of the cases, hip dysplasia is a global dysplasia. It looks like a small hat. You cannot cover your head. This is type 1. Morphological abnormalities of the whole femur. You have the whole femur, but it's not the normal position. You look to this patient, the patient has the whole femur, but the femur is transverse. It seems like this patient is measuring the anteversion. This is the proximal femur and this is distal femur, but this is normal AP. So the position of the femur is inflection 90 degrees. So the whole femur is there. It's short, but morphologically it's not in the normal position. And the patient, as you see here, we don't think that there is a treatment for such type. She can function, and there is no treatment. Actually, I treated one case before, and I corrected the flexion, and within few months, there was recurrence of the problem again. Again, morphological abnormalities like this case. You see the severe deformity on both sides. Again, we suggest that there is no treatment for such cases. Type 2, congenital abscess. Either total absence of the femur or partial absence of the proximal femur. This is total absence. There is no femur at all. And this is accompanying fibular hemilia, there's no problem. With older age, at the age 16, this is the tibia. The tibia takes the shape of the femur. If you have a completely absent femur, you see this unilateral case? This is the medial tibial condyle. And again, you don't need a treatment. And this is an example of the total absence on both sides in the young age. So type A, total absence of the femur on both sides, you see. Total absence, again. This is the tibia. Partial absence. In partial absence, the proximal tibia is not there. This is the partial absence. There is no proximal tibia. And this is an example of bilateral case. This is type 2. This is type 2A. Complete absence. Type 2B. Absence of the proximal tibia, as you see here. Type 2A, total absence. Type 2B, absence of the proximal tibia. Type 3, abnormal proximal femur. Type A, apparent neck pseudoarthrosis. And this is an example. you see, there is no apparent continuity between the head and the proximal femur. This is not true. There is something in between, fibrocartilage in between, like this. It looks like a pseudoarthrosis. It's not pseudoarthrosis, it's apparent pseudoarthrosis. Type B, you have coxavara. You see coxavara, this is bilateral type 2. In this case, type 2. So type 3, we have A, apparent neck pseudoarthrosis, or B, coxavara. Type 4, it's almost normal femur, but short. And in such a case, you do just lengthening. This is type 4. I will show you an example of type 3, the apparent neck pseudoarthrosis and coxavara. This is an example of the apparent neck pseudoarthrosis. You see we have a pseudoarthrosis, apparent neck pseudoarthrosis, coxavara on the other side. And that had been treated on the other side by valgus osteotomy. We don't know why. And with follow-up, you see the femur. The angle is about 130 degrees. With 3D, you see the shape of the femur with severe angulation. Some people think it's not possible to interfere, and there is no value of interference. But we had another case who refused the intervention, and the patient came at the age 24. He had sciatic nerve palsy with severe pain. He cannot sit because of this angulation. So what we do distraction histogenesis for the apparent pseudoarthrosis, as you see here. We fix the pelvis and the proximal femur together. We fix the distal femur, and we do distraction histogenesis. You see bone formation during distraction. Bone formation, more distraction, more distraction. You see the bone formation. And after 4 years, you see the length of the femur. And this is for pelvic support osteotomy afterwards. You see before and after. Again, apparent neck pseudoarthrosis. You see this patient, no continuity, with follow-up, more follow-up, more follow-up after age of 3 years. At the age of 3 years, we do distraction. The distraction stimulates the fibrocartilage in between, you see. You see the bone formation during distraction for about 4 months. And this is the end picture. Follow-up after 1 year and 8 months. We just stimulated the bone formation in this area. This is before and this is after. Again, the apparent neck pseudoarthrosis, another example. This is at birth, and with follow-up, it seems like there is no neck, head on neck, more follow-up, the apparent pseudoarthrosis, again look. With distraction to stimulate the bone formation, you see the bone formation. And the valgus osteotomy. Remember that you have retroversion and you can correct it at the same time of correction of the angle. We usually use the valgus or varus plates. It makes your life easier. Again, apparent neck pseudoarthrosis. In this case, you see with the follow-up. The problem with the classifications that sometimes you will see one picture of the patient. You cannot give the classification you want. So you have to follow up the patient to give them the right classification. So with more follow-up, and we did valgus osteotomy. And we reduced the hip. The hip is okay, so the patient is valid for lengthening. And plate removal, and at the same time, femoral and tibial lengthening. Type 4, almost normal hip and short femur with a stable hip. And we did just lengthening, as you see here. With 7 years follow-up. In conclusion, this is the new classification. Type 1, morphological abnormalities of the whole femur. The whole femur is there, but it's not the proper position. Type 2, congenital absence. You have a total absence. And you have a total absence. The tibia will take the shape of the femur. Partial absence of the proximal femur. And in the you have partial absence of the proximal femur, you can do pelvic support osteotomy. Abnormal proximal femur, you have an apparent nexodarthrosis, which is usually a valid candidate for distraction osteogenesis. Then you do pelvic support or lengthening. Coxavara, and you can correct the deformity and do lengthening. Short femur, you just do lengthening. For hip dysplasia and knee instability, you have to judge each case by itself. There is no rule at all. Thank you.
Thank you very much, Professor Dr. Gamal. And as usual, it is a very magnificent and very impressive lecture. In fact, you changed our minds a lot about congenital femoral deficiency. I hope all of the audience will change their minds concerning this very difficult problem, which is very rare, but it's really very difficult to treat. Thank you, Professor Dr. Gamal.